Now I think we've moving on to control of myopia and the measures that we are having, and we have a very experienced and very prolific Dr. Jitendra Jitani, who's going to talk about his landmark work on atropine and myopia control, the present status and the future of atropine in India.
Thank you so much. So, welcome everybody once again. I would be speaking mainly on the myopia control with atropine that we have been doing since years. This all we have discussed. I will just skip these slides. We know that what is going wrong. We already heard from Dr. Aditya, Dr. Koheli. These are some of the risk factors as to how myopia progresses. If parents have myopia, kids are more likely to have it. Outdoor activity does make a difference. We already saw that. Near work amount of light does result in myopic progression. Height increase does correlate with the growth of size of eyeball. There have been multiple articles on all this. This particular article I like to quote in most of my talks, mainly because it has enlisted all the risk factors, including low outdoor activities, near work, dim light exposure, rural urban divide, use of LEDs, low sleeping hours, reduced near work. So, how has atropine come for myopia progression rescue? So, it is one of the most important point is that we are talking not about myopia, we are talking mainly about myopic progression. We should not forget that we are talking about myopic progression, and that too axial myopic progression. So, post atom 1, atom 2 studies, I think there has been a significant rise in the use of low concentration atropine. There has been a renewed interest in atropine because now we have a atropine drops which really doesn't have much of side effects. When we reduce the concentration of the drop to 0.01%, we really don't know how it is working. So at this point of time, we mainly know that atropine affects dopamine neurotransmitter release from the cellular stores, and this may influence the retinal signals that control the growth of eyeball. This was one of the landmark studies. There have been previous articles before that also. Atropine has been used now since last 50 60 years for control of myopia, but this is one of the classical studies where they had randomized one eye with other eye, 400 Singapore children. One eye was getting 1%, other eye was getting placebo. And what happened was that atropine 1% was very good in treating or in controlling rather the progression of myopia, and most of the children ended up being anisometropes at the end of 2 years. Now they followed this up with another great paper in reducing the concentration from 1%, 0.1% and 0.01%, thinking that when you reduce the concentration in allopathy to 100 times, you are actually getting a placebo effect. So they did not use a placebo in atom 2 study, taking 0.01%, thinking that this would be a placebo, and to their surprise they found that atropine 0.01% also had some effect in controlling the progression of myopia. Now what are the advantages? We all know once you reduce the concentration to 0.01%, we have almost minimal to nil side effect of accommodation, other systemic side effects. Retardation of progression was not exactly dose dependent, but we will see in lamp 1 and 2 that it is dose dependent. lamp what lamp study gives us is that it further goes down into stepwise increases in the concentration. So now we have 0.01% and 0.1% working for myopic progression. What next? The next was this particular thing where they started seeing 0.01%, 0.025% and 0.05%, and they found in their lamp 1 and lamp 2 both the studies that it was indeed a dose dependent response, with 0.05% giving a better response than 0.01%. I like this particular study a lot, mainly because whenever a new drop comes, the company pressure and the company driven market is so aggressive that people start using atropine for myopia, not for myopic progression. So you, as Dr. Koheli told, that once you have a new myope, you have to find out whether he's progressing or not. All these drops, all this discussion, all this drama is about progression of myope and not really about myopia. Myopia is being successfully treated with glasses since years. So this particular study also shows that atropine has got no effect on cornea, lens or any other parameter except axial lens. So we cannot give it for astigmatism. No anecdotal, no evidence is there for that, because we keep getting emails from parents and sometimes doctors also. So where does this all this discussion and all these publications are there. If you search internet, there will be more than 150 publications on low concentration atropine in last 10 years. So atropine eye drops do reduce the progression of myopia, concentration dependent. As per lamp 2 study, the concentration of 0.01 does hold value, and it is the only drop at this point of time available in our country. We can increase the concentration in non-responders. We will see some of our work on that. Patients may respond if they have not responded to 0.01%. This was one of the first studies done in our country, which we presented in 2018 AIOS. This was a 3-year study. We did a 3-year study to find out what happens when we compare 0.01% with no drops. So we found that atropine was pretty useful. We did a small study on compliance. It is very important to understand that we are going to use these drops for over a period of 2 years. So we have to know that patient is compliant with these particular drops. And 0.01%, we used it. We compared head to head what happens with single and twice a day usage of low concentration atropine. We found that twice a day usage was better, provided better or tighter control on the prevention of progression. We also used twice a day in non-responders to low concentration 0.01%, and almost 33% of them did respond when we increased the frequency of eye drops. We are not increasing the concentration. We just have got 0.01% with us. And this was the study which Dr. Ashina showed about pre-myopes, which we did. And this I already shown. Quarantine myopia is not in this. Yeah, this was another. I think this is also one of the studies which shows that atropine has nothing to do with accommodation when it comes to control in myopic progression. We did this study. We did it, I think, in 2019. We looked into the data and we found that atropine was useful in children who were pseudophakic and were having myopic shift beyond the age of 5 years. So sometimes, we operate pediatric cataracts. We have patients who are having a lot of myopic shift post cataract surgery, even once their age is beyond that particular progression age. So atropine does work in those patients also. These are some of the curves from what we saw the data. So is it really safe to use a low concentration atropine eye drop for long term? Atom 1 used 1%. We are talking about 0.01%. So systemic side effects would not be really holding anything. We did pattern ERG to find out whether it is useful or not. We published it in 2019. We did some work on whether it affects higher order abrasions. There have been three cases reported by Mihir and his group, where they said that there were some post-op patients who were myopes, intermittent exotropes, operated, and post-op they started developing esophoria or esotropia, mainly because it inhibits the accommodation a little bit. And so that was there was more accommodative effort, and that was leading to esotropia. There can be allergy to atropine. It is at the end of the day a sulfa drug. Pupil size change was not much. We already presented our data on that, and neither was near point of accommodation changed much. So I would like to thank everybody for being in our course, and
Thank you,
thank you.
sir. That was a really insightful talk, and I think the drive home point at here is that all the major studies, the atom, the lamp, they studied myopia and not myopia progression.
Yeah.
And that was one of the limiting factors I felt when we
Yes.